In this last section of the osteoporosis case, we will look at the treatment and we will consider the case presentation and make some comments. So regarding the treatment, there is encouraging data that shows that treatment for osteoporosis can decrease fracture risk by nearly 50%. Calcium supplementation of 1200 milligrams per day in females greater than 70 years of age, along with at least 800 IUs of vitamin is recommended. And vitamin D enhances calcium absorption from the small intestine. Because serum calcium concentrations are closely regulated, if losses of calcium in urine and feces are not replaced in the diet, parathyroid hormone secretion will increase to compensate. This secondary hyperparathyroidism can lead to continued small losses of calcium. To these measures may be added muscle strengthening and balance exercises and hip protectors to prevent falls and hip fractures. Medical therapy is divided between the following two major classes of agents: anti-resorptive drugs, which are drugs that inhibit osteoclastic activity, and anabolic drugs. These are drugs that act on the osteoblast to stimulate bone formation. So first let's talk about the anti-resorptives. Estrogen is a powerful agent to treat postmenopausal women with osteoporosis, working by inhibiting signaling of rank ligand between the osteoblast and the osteoclast. But the Women's Health Initiative has shown that long-term use of estrogen and progesterone is associated with 26% increase in the risk of invasive breast cancer. Consequently, most physicians will be reluctant to use estrogen to treat osteoporosis, and of course, it is contraindicated in women with a history of breast cancer. Selective estrogen receptor modulators, or SERMs, such as tamoxifen and raloxifene, like estrogen, block release of cytokines from osteoblasts. While both of these SERMs block estrogen action on the breast, tamoxifen is associated with a greater risk of developing endometrial cancer. Raloxifene does not have this adverse effect on the endometrium. Molecular studies have revealed that while raloxifene and estrogen bind to the same region of the estrogen receptor, they cause different changes in the three-dimensional structure of the receptor. Bisphosphonates have become the most widely used anti-resorptive therapy for osteoporosis. These drugs are carbon-substituted derivatives of inorganic pyrophosphate, or PPI, that, like PPI, bind tightly to hydroxyapatite crystals. They impede bone resorption by blocking osteoclast attachment to bone and by hastening programmed cell death. Oral agents include alendronate and risendronate, and an intravenous agent, zoledronic acid. Many experts recommend discontinuing biphosphonate treatment for after 5 years, with the dividend that in the ensuing 5 years there is minimal bone loss. Erosive esophagitis used to be fairly common with daily biphosphonate dosing, but now with weekly or monthly regimens it has receded as an issue. Serious but rare is osteonecrosis of the jaw, which is more common after oral surgery, but can occur spontaneously. Osteonecrosis of the jaw is usually associated with high-dose zoledronic acid for treatment of myeloma or other bone cancers. With a full understanding of the role of rank ligand in osteoclastogenesis, it is clear that rank L is a potential site for anti-resorptive therapy. The monoclonal antibody denosumab exploits this opportunity by binding to rank L, thus limiting its action in stimulating bone resorption. In a clinical trial, denosumab was administered by one subcutaneous injection and suppressed bone resorption by up to 81% for as long as 6 months. Once the effects of denosumab have worn off, however, bone turnover returns to pre-treatment levels. The lysosomal enzyme cathepsin K, which is involved in enzymatic degradation of bone, is now targeted by a specific inhibitor, odanakatib. While the drug suppresses bone resorption, it does not affect osteoclast survival. Now let's talk about anabolic therapy. Anabolic therapeutic options are more limited than anti-resorptive therapies. First and foremost is PTH, or parathyroid hormone, the N-terminal fragment termed teriparatide. The parathyroid gland senses changes in extracellular calcium through a cell surface calcium sensing receptor. Consequently, PTH plays a vital role in regulating calcium homeostasis. Increased serum calcium decreases PTH release, while decreasing levels of calcium trigger PTH release. PTH also stimulates 1-alpha hydroxylase activity in the kidney, increasing the formation of the active form of vitamin D1 25-dihydroxyl D. Although constant high levels of PTH, as in primary hyperparathyroidism, have long been known to cause bone resorption and osteotitis fibrosis cystica, low and intermittent doses of PTH promotes bone formation. One observation that accounts for the anabolic effect of low-dose PTH is an increase in the lifespan of mature osteoblasts. There may be other effects of low-dose PTH that have yet to be defined. Low-dose teriparatide administered subcutaneously on a daily basis increases bone mass and reduces occurrence of fractures. Because of a concern for development of osteosarcoma, it is recommended that PTH use be restricted to 2 years. Another anabolic therapy in clinical trials is inhibition of WNT antagonists, especially DKK1. This inhibitor, BHQ-880, blunts the effect of WNT on causing bone accretion. Blocking DKK1 action therefore allows the anabolic effect of WNT to be expressed. And finally, some comments on the case presentation, which was the case was given in the first part of the videos. If you look in this section, our patient is at risk for additional fractures based on a history of vertebral compression and a T-score in the osteoporosis range. She is a candidate for alendronate or risendronate to be administered for 5 years. A calcium intake of 1200 milligrams per day, preferably in her diet, but with supplements if necessary, is important. And determining 25-hydroxyvitamin D levels is also advised. And if low, she should receive vitamin D supplementation of 800 to 1000 IUs per day. And a DEXA scan should be repeated in 1 year and then every 2 years to assess the efficacy of biphosphonate therapy.